Afternoon, chat. Today we'll do a case of a 38-year-old female who's coming into clinic for renewal of her Coversyl, and also to inquire potentially whether she is pregnant or not. She's currently 3 weeks late on her cycle. So you go in and see this patient in the room, and her blood pressure is well controlled at 135/80, and she does a urine sample for us, and the urine sample is positive, so she is pregnant. Last menstrual period was about sort of 7 weeks ago, so putting her in that range for pregnancy. So you come back out wondering, what we should do with this specifically. Can we renew that medication? And what do we start setting up regarding this specific pregnancy? So first and foremost, what is Coversyl? So Coversyl is the actual trade name. The chemical name is perindopril. If you don't recognize that class, that's an ACE inhibitor class, so an angiotensin converting enzyme inhibitor. Generally, what I get residents in the habit of doing, or even medical students, is trying to remember two other medications in that class. So when you come across a new drug, just try to ask yourself, what are two other drugs? Try to remember both the trade name and the chemical name. So for ACE inhibitors, there's Altace, which is Ramipril, there's Mavic, which is Trandalapril, there's Vasotec, which is Enalapril, Acupril, which is Quinapril. There's a whole bunch of them, but just try to remember two if you can, just so it sort of stimulates that memory reflex. Coversyl is a good ACE inhibitor. Starting dose is generally looked at to be 4 milligrams, unless you're dealing with the elderly, in which case we start slower. We start at 2 milligrams. Max dose is 16 milligrams per day. So this is what she's actually taking. And to understand how it works, you have to look at what this specifically affects and why that's effective in blood pressure. So to understand ACE inhibitors, we have to look at a system that's present within the body that's essentially responsible for regulating blood volume, electrolyte balance, and systemic vascular resistance. And that system is called the RAAS system, RAAS system. And it stands for renin, angiotensin, aldosterone system. And the three really active chemicals that we look at in that system are renin, angiotensin 2, and aldosterone. So essentially, small changes in blood pressure are affected by baroreceptors that are secreted around our various system, but acute and chronic changes are more a function of this specific system, this RAAS system. The starting chemical for that is renin. Renin is something that is made in the kidney, in the juxtaglomerular cell. It sits as a prorenin. It is then cleaved into two renin molecules, and then assert its activity on a chemical that's actually secreted by the liver called angiotensinogen. So what stimulates renin to be released? So if there's a decrease in vascular perfusion, so there's less blood flow to the actual kidney, or it's picking up that there's less sodium in the actual tubule, it'll actually create that cleaving of prorenin to renin. And then renin, which is actually an enzyme. So what first and foremost is an enzyme? An enzyme is a protein that speeds up a chemical reaction within the actual body. So in this particular case, it facilitates the conversion of angiotensinogen to angiotensin 1. And then angiotensin 1, which doesn't serve a lot of functions. Of angiotensin 1 affects in certain degrees bradykinin levels and substance P. We'll get back to bradykinin levels potentially later on when we look at side effects. But essentially, it's converted by another enzyme called angioconverting enzyme into angiotensin 2. Now, angiotensin 2 is a very active chemical. It essentially has about 5 functions. So angiotensin 2 causes direct vasoconstriction. It acts on the smooth muscle around arterioles and makes them constrict. It then also acts on the adrenal cortex to actually stimulate the formation of aldosterone, which we'll get to in a second. It acts directly on the kidney to stimulate sodium reabsorption, which increases volume, which increases blood pressure. And then it has 2 effects centrally. So it actually affects or encourages sympathetic outflow from the central nervous system. But then it also stimulates the hypothalamus to secrete vasopressin. Vasopressin is also called antidiuretic hormone, and that in and of itself, also causes vasoconstriction, and it also stimulates water reabsorption from the kidney, which also increases volume. So you can see how this is all increasing blood volume. And then when we actually look at aldosterone, so aldosterone is secreted or made in the adrenal cortex. And it's secreted in response to 3 general stimuli. One is angiotensin 2 causes that to happen. Another one is ACTH, which is secreted by the pituitary, which is adrenocorticotropic hormone. And then there's also extracellular potassium levels, which will stimulate that release as well. And it functions in two different fashions. So it also acts on the kidney to stimulate sodium and potassium reabsorption, so increasing those levels. But then it also acts centrally to cause us to be more thirsty, so to actually drink and bring in more exogenous water into our system, again, all of which will increase blood volumes. So understanding that pathway will allow us to then sort of see why we choose these medications in the first place. So obviously, perindopril or Coversyl is going to be acting as an ACE inhibitor. So it's going to inhibit that conversion step from angiotensin 1 to angiotensin 2. So everything downstream of that will be affected. And that's why that's actually effective in blood pressure. But what are the actual contraindications to ACE inhibitors? And one of the big ones is actually pregnancy. It's an absolute contraindication because it can cause teratogenicity. And that may have something to do with, they've looked at angiotensin 2 receptors, and there's two subtypes. And the second one is actually present in great amounts in fetal tissue. But the actual overall mechanism is multi-pronged. So there's lots of effects that it can have that are negative. The other absolute contraindication is if you're actually allergic to the actual molecule. So if you're allergic to angiotensin converting enzyme inhibitors, you can't take it. And then there's some softer indications, one of the bigger ones being aortic valve stenosis. Because ACE inhibitors are such an afterload reducer, it can cause some problems. If you're depleted in volume in general, because it causes further depletion, it's also a contraindication. If you have angioedema or swelling in response to certain chemicals, then it's another contraindication. And you just want to keep those in mind when you're looking at these in terms of their use in general. So having recognized that, what's going to happen in this particular case is as soon as you bring up the fact that is a problem in pregnancy, this patient's going to be concerned. And so they're going to want to know what impact has that already had and has this compromised the pregnancy? So they've done a number of studies looking at this. And while there's one or two studies that were done early on that showed that ACE inhibitors are a problem throughout all of pregnancy, there's general consensus that that was sort of poor information, and newer studies they look at now show that actually in the first trimester, ACE inhibitors aren't as big a problem. It's really in the second and the third trimester that they cause some big issues. So that's good information for us because we could reassure a patient like this because she's only 7 weeks along or somewhere in that area, and it really wouldn't be a problem if she was on an ACE inhibitor. Now we would want to change her, and what could we potentially change her to? In Canada, the biggest one we probably use, there's a beta blocker called labetalol. It's his chemical name. Trandate is the actual trade name. It starts at usually 50 milligrams twice a day. If you're concerned about dropping the blood pressure too much, 100 milligrams twice a day is probably equivalent to 4 milligrams of perindopril. So 8 milligrams would probably be equivalent to maybe 200 milligrams twice a day. Now, this particular beta blocker also has alpha activity, so it acts on the alpha receptor as well when we're talking about adrenocortical receptors. So because of that, I probably wouldn't put her on 200 milligrams twice a day. I would just initiate potentially 100 milligrams twice a day and just see how well her blood pressure responds. Other options we could have, there's a calcium channel blocker called nifedipine. The trade name is Adalat, which also is safe in pregnancy. And then there's some diuretics, thiazide diuretics, hydralazine. Those are also safe in pregnancy. So you can certainly make those substitutions and you'd be, sort of on a better path. The other issue you'll get into a lot is with this particular age group, especially when we've now mentioned that the medication could have an impact. Generally, we get into this discussion about what is the problem with being 38 and having a pregnancy in the first place. And there are some things you should be able to talk with them about. First and foremost, generally, patients are concerned about the risk for Down syndrome. So when you look at those numbers, if you're 25 years of age, the risk of having a Down's pregnancy is 1 in 1,250. If you're 30, that goes down to, or goes up depending on the way you look at it, to 1 in 1,000. At 35, it's 1 in 400, and at 40, it's 1 in 100. Now, the only thing I tell you two things about that. One, always keep in mind that means that 99 out of 100 pregnancies are fine. And if you were given the choice of taking a test where you get 99%, I think most of us would take that. And the other thing I would tell you too is that never forget that Down's babies are really wonderful babies. And I don't mean that other chromosomal abnormalities are not, but Down's kids are specifically really, really sweet, really, really gorgeous. And you don't want to miss that. I understand the limitations. I understand people wanting to have perfectly healthy pregnancies, but Down's children are really wonderful children. The other numbers you should know just about chromosomal abnormalities in general, and what are the rates of those specifically. So at 25, the rates of chromosomal pregnancy abnormalities in pregnancy about 0.2%. At 30, that goes up to 0.3%, so not much of a jump. 35, you're looking at it doubling to 0.6%, and at 40, you're looking at almost a tripling to 1.6%. So that's certainly relevant. So the more important thing is looking at specific miscarriage rates. And the numbers you should hold on to in that particular case is that at 30 years of age, the miscarriage rate is just below 10%. If you go up to 35 years of age, that starts to accelerate into the high teens and maybe as high as 20%, depending on what study you look at. If you now cross over to 40 years of age, miscarriage rates will actually approach 40%, so the high 30s to 40%. And if you're looking at 45 years of age or older, that miscarriage rate can go as high as 60 to 80%. And those are certainly numbers that you should retain because patients will be asking you, what that percentage chance is, because sometimes it's not always planned as we get older, which is happening more and more often in this particular setting. So the only specific advice I'd give to this patient, beyond sort of getting things rolling with respect to doing blood work and filling out forms regarding the pregnancy, is certainly to take prenatal folate because that's something that you should be taking to sort of help development with the pregnancy. And there's all kinds of studies that show that that's the case. Otherwise, we would have switched her to the actual different medication for her blood pressure. And then we would set her up to see somebody, whether she wanted to see obstetrics and gynecology or midwifery, so that she could follow along with the pregnancy. So this is a pretty basic case today, not too complicated, but there's certainly things that we want to go over and understand as we're addressing these specific types of cases. All right. So we'll see you for another case another time. I hope everybody has a good day.